Okay.
We're live in 5, 4, 3, 2, 1.
Yeah. Good evening, everyone. We welcome you all to Ortho TV in association with Orthopedic Research Education Foundation. To introduce today's speaker, I hand over to Dr. Janki Badani, the Secretary of Oref.
Good evening, sir. Good evening, everyone. So today we have Dr. Ananda Kishore Pal from PGIMR Kolkata, who is taking a lecture on amputation. Once again, welcome to Orthopedic Research and Education Foundation India, and I'll over to Dr. Pal, sir.
Good evening, everybody. I'm very much indebted to Dr. John Mukhopadhyay. He's doing the relentless work on spreading the knowledge to our next generation. So I'm very much delighted to become associated with him, and Dr. He's also doing excellent job of coordination and moderation of this meeting with the lecturers as also our next generation. So without wasting the knowledge, I am just started with a very, very important topic, which is not only the bread and butter of orthopedic surgeons, but also a very, very general topic of general interest for the students as also the young orthopedic surgeons. And in dire emergency, there's immanent knowledge that will become excellent deliberation, and that will lead to the production of the new organ, that is amputated stump. And the skill is extremely important. For skill and knowledge both are important for production of a new organ, that is amputated stump. So without wasting the knowledge, is my just a minute, I am to share the screen. Huh? Okay,
you need to share your screen.
Yes, is it visible now?
Yes, sir.
Yes.
Please.
Thank you. So this is we have to know the new organ. So I'm telling that this amputated stump as a new organ because there are several reasons I'm going to disclose. So the history is basically, it is coming from the Latin, it's amputere, to cut away, but without coming the English word, the amputation is the first applied to the surgery in 17th century, which is possibly by the Peter Lawes, the discourse of the whole art of chirurgy. Just disclose that. And there are several surgeons, apart from the Ashwini Kumar from the Rig Veda. There are several surgeons, they have described that. I'm not going to detail. The indications basically, this is a dead, dangerous, or the damn nuisance. Dead or dying, when the part is dead or dying, it is very imperative to keep it with the body, like the peripheral vascular disease, severe trauma, burns, and frostbite. Dangerous means a malignant tumor, potentially lethal sepsis like grass gangrene or the crash injury. And damn nuisance, when there is absolutely functionless because of there is uncontrollable pain or recurrent sepsis, gross malformation, or severe loss of function. So in these cases, so there is a high indication of amputation. Now, what is the evidence? So by which scientific evidence will guide you that this limb is out of the way, it doesn't work, and that has to be amputated? There are several scores are there, like the Mangle Extremity Severe Score, the Limb Salvage Index, and several others. And lastly, the most important is the Ganga Hospital Open Injury Severity Score. Now, they are considered the several parameters like age, shock, warm ischemic time, bone injury, muscle injury, skin injury, nerve injury, of which the most important, that is the latest one, is the Ganga Hospital Open Injury Severity Score. I'm very proud to say that is the Rajashekaran of our community. They have developed this, and this is extremely helpful for this. But for historical interest, those who are very old-fashioned examiner, they also ask me the Mangle Extremity Severity Score. That is how we have to know the basic things. What is the actual score by which we can go for the amputation? For the MES, it is that is Mangle Extremity Severe Score. It is the cutoff limit is the 7. Just make it double. That is it's 14. That is, if the score is below 7, then in Mangle Extremity, that we can salvage, we can put the limb, we can try to keep the limb with some medication, whereas or surgery. But if it is 7 or more in as per Mangle Extremity Severe Score, there's high indication for amputation. But in the latest development score, that is the Ganga Hospital Open Injury Severity Score. If the score is less than 14, then we can keep it. We can keep the limb. We can save the limb. Otherwise, if the score is above 17, it is a definitive cut-off line by which we can, the limb can be amputated. Whereas if the score between the 14 to 17, then there are several. We require some experience that skin injury. It is looking like very severe, but we can keep it. We can keep it, and we can repeat it debridement that at within 48 hours or 72 hours, so that we can understand the behavior of the skin, and we can keep it. So between 14 and 17 score, experience is required whether to save the limb or to sever the limb. So this is the important, this is the absolutely important score we have to remember. Now, what are the level of amputation? Basically, you have to tell classically the level of the amputation can be done through the bone. Like the amputation through the tibia, it is known as the transtibial. If it is through the knee, it may be knee disarticulation, or it may be to the femur, it is a transfemoral amputation, like that. So it is very easy. But for the foot, you have to know which type of amputation it is. Again, we am coming. So it may be toe amputation, it may be transmetatarsal amputation, it may be through the tarsometatarsal joint, that is the Lisfranc joint, or through the midtarsal joint, that is between the talus and the navicular calcaneum and the through the midtarsal joint, that is known as, or if it is through the ankle, the through ankle, that is basically is known as the Symes amputation. There are several modifications we can discuss. Now, what are the types? It may be asked. It may be either a closed amputation, that means elective procedure, skin is closed after amputation, but there's an open amputation like a guillotine amputation that is done in a very, very emergency situation for the life-saving procedure, whether there is no time to close the joint, because just to save the life of the patient, we have to remove the limb, so that there's the affected parts, the dangerous part or the dead or dangerous part, that is removed. So wound is left open over the amputation stump. It is not closed. It is done in emergency procedure. Now, if it's the closed amputation, there are two types. It may be subtypes, like the myodesis or the myoplasty. Myodesis is very, very important. We have to understand myodesis where the muscle is sutured to the bone. And the myoplasty is one where the opposing muscles, the agonist and antagonist, that can be sutured across the bone to the opposite muscle group under the appropriate tension. This is most important. Now, what is the ideal stump? The ideal, it is a very, very favorite questions. So, and you have to understand for our better serving of the amputation stump, better preparation of the amputation stump. The amputation stump should have the ideal length. So what is that ideal length? I will come in the next slide. Now, the amputation shape. See, there are two shapes are given. The one is the cylindrical, another is the conical. Most important shape, which is ideal, is this one, that is the cylindrical. Or it may be a little bit tapered like the screwdriver shape. That is the ordinary screwdriver. It is not used nowadays. Now, this ordinary or machine screwdriver shape it look like. That will be why it is important. Why the conical shape is not popularized. Both can be done, but this cylindrical shape is much more it is beneficial, because of some square shape that can prevent the relative movements inside the socket. That provides a very, very firm contact with the socket of the prosthesis. That will have a very, very comfortable during the walking of the amputee. Now, what is the ideal scar? Ideal scar should be posterior, non-tender. It should be less bulky. It should be freely mobile over the muscles of the underlying muscles or the underlying bone. It should not be adherent with the underlying structure. Now, skin should be optimum. It should not be very much redundant. Redundant skin is not at all beneficial. It should be vascular. It should have normal sunset and should be painless. And next is the amputation stump. This is the organ. This should be fully mobile. Suppose this is the below knee amputation stump. It should be fully mobile. So that means the full mobile, there's full range of motion as the normal knee joint should enjoy. And there is no deformity. The amputation stump has a very, very propensity to develop the deformity. I will come there later on. This sort of deformity is very, very detrimental for the functional relief. That should be avoided. Now, in the end portion of the stump, it should be capable of weight bearing. If it is a cylindrical one, it is easy to, if he wants, patient can give some weight on this. But if it is a conical one, it is very difficult and it's very disadvantageous to give weight on this. So if the patient is tries to make a rest on a elevated part of a rock of a house or a chair, but this sort of stump is beneficial than this conical stump. So end bearing stump is much more desirable than this non-end bearing stump. Now, how to ascertain the level of the amputation? This is very, very pertinent questions. Where to cut the joint? Where to cut the limb? Now, level of the amputation should be done through the vascular area. That means that it should be distal to the digitally palpable pulse. So this digital palpable pulse should be there. So so there will be no vascular jeopardize, or there is sound healing of the bones or muscles of the amputation stump. The most important, the evidence which required for exact site selection, it is a transcutaneous oxygen pressure, and also there is the ankle brachial index, which is done by the Doppler ultrasound. What is that? Now, this is for the malignant tumor, it is very easy to determine the level of the amputation, because that depends on, this is the classical picture which is taken from the Appler's textbook. So basically, this is a very, very important picture that can be, that the amputation can be done by interlational, marginal, wide amputation, or the radical amputation, depending on the nature of the tumor, depending on the histopathology, depending on whether it is extracompartmental or intracompartmental, or if there is some already metastasis or not. So this is it's very easy to take the decision for the malignant tumor. But the peripheral vascular disease, if there's or peripheral occlusive vascular disease, if it is there, then we have to perform this. There is transcutaneous the oxygen pressure measurement, and if this transcutaneous oxygen pressure measurement, it is usually done by a receiver with a transducer. It's just like a ECG lead. If it is just placed on the skin, or like if there is ulcer or the nephrotic area where we are suspected avascular changes, these leads are placed on the skin, and that is being recorded through a recorder. And if this pressure is automatically recorded, if this recorded pressure is less than 40 millimeter of mercury, then it is ischemic. Then what is done? Then the patient is allowed to breathe 100% oxygen at 1 atmospheric pressure for 20 minutes. Again, that pressure is measured. If now the pressure is normal now, then we can ampute through this. And after the operation, that patient should be treated with the hyperbaric oxygen. But if that's again, there is another that if it is not achievable, then again the patient is subjected to take the breathing in a hyperbaric chamber with at least 2.4 atmospheric pressure at 100% oxygen. Again, we have to measure whether it is coming to 40 millimeter or not. If it is again the achieved 40 millimeter marker is not achieved, then we have to go the above level. So suppose it is not achieved at the ankle, we have to go to the knee level or below knee level, like that. So you have to go in the above level. So this is the way by which we can choose the exact level of the amputation. So this ankle brachial index, it is done by the handheld Doppler device. The ankle systolic pressure is measured. The ankle systolic pressure is divided by the brachial systolic pressure, is basically its ankle brachial index. And the normal parameter, it should be remembered, it should be 0.9 to 1.3. If it is less than 0.9, it is abnormal. If it is more than 1.3, that means the vessels are calcified and the results are not reliable. So the cutoff mark is ankle brachial index is 0.9. Again, the transcutaneous oxygen pressure measurement through the skin, it is again the magic figure is the 40 millimeter of mercury. If it is less, then we can subject to do hyperbaric oxygen, and we have to measure the pressure again. So that is the way by which you can measure the exact site. Now, what is the ideal length? We can keep the whole of the limb. See, suppose it is a below knee. Suppose there is any injury on the foot, we can keep whole of the leg. Is it possible? No. Basically, we have to keep the optimum length. Why? Because this is the liver system. See, this is for the leg level. So knee is the fulcrum. see that it is the quadriceps, so it is the power, and whole of the limb, just the rest part of the limb, it's acting as a load. It is just like a third class lever. So if we increase the load arm, so that is a disadvantageous. So we have to keep the optimum length. So very long stump is not desirable. That is why this optimum length is required. Now, what is the optimum length? Just measure, just remember this figure: 3, 4, 6, 9, 11. 3 inch means the 3 inch for the upper limb is 3 inch above the wrist, 3 inch above the elbow. Otherwise, always if you go down, or below the knee, below the elbow, or below the shoulder, is always 4 to 6 inch below the knee, below the elbow, or below the shoulder. And 9 to 11 is basically for the transfemoral amputation. Whereas 9, that should be the cut should be done 9 to 11 inch below the tip of the greater trochanter. So that is the 3 inch, 3, 4, 6, 9, 11. So these are the figures to be remembered for the exact length of the amputation stump. Now, what is the technique? The skin flap. Skin flap may be anteroposterior or the medial lateral. Total length should be equal to 1.5 of the total circumference of the amputation level. Length of each flap should be either equal or the long posterior flap, especially especially for the below knee amputation stump, especially in the where there is a vascular problem is the issue, because posterior part vascularity is much more. So for the below knee amputation stump, long posterior flap is basically it is used for the lower limb. Now, tips of the technique. Whatever we have to preserve the joint, we have to smooth the cut end of the bones, like for the tibia, it is a transtibial amputation. The lower part of the tibia, anterior part of the tibia should be cut 45 degree. And for the femur, the anterolateral part of the femur should cut, because that can cause the irritation under the skin that will lead to the sinus formation. Now, cover the bone with the muscle and the soft tissue is the myoplasty. I'll come what is the myoplasty and myodesis. And how to cut the nerve. Nerve should be dragged forcefully, and we have to cut cleanly so that it is go proximally and it is buried inside the muscles, so that the neuroma formation will become less painful. Next is we have to ligate the blood vessels securely, preferably the double ligature. Now, how they have to use the skin? You have to use the widely spaced simple suture is like that. It's widely spaced simple suture like that, because mattress, if you see, if the mattress is given, mattress causes the significant ischemia. This is the vascular study is done. This is the widely spaced simple suture, and this is the intermittent mattress and the simple suture. This is the much more. This is the most easily most beneficial. This is the less beneficial, and this is the least beneficial, because if you do the mattress is very closely mannered, that will cause severe vascular geoparters, and the end result is like that. Next is the adequate strum drainage. Always we have to give some drain and for prevention of the hematoma, and ultimately you have to give the rigid dressing. Rigid or soft dressing, the rigid dressing is important, and we have to, especially for the stumps splintage. Now, the muscle management, it is come, see, this is the muscles. If it is the transfemoral amputation, most powerful muscles is the adductors and the hamstring. If we not properly sutured with the bone, what will happen? So that the other muscles, that is the abductors and the flexors, that will cause the abduction and flexion abduction contracture, flexion abduction position. If it persists for a long time, that will lead to flexion abduction contracture of the stump. That is how, so we have to use, the muscles should be sutured securely to the bones, preferably the most important muscles, which will cause, will make the limb in a neutral position. That is how for the transfemoral amputation, the adductor muscles, especially the adductor magnus and the hamstring, should be sutured to the medial side as also the posterior side subsequently. So that can be performed in the above knee amputation, as I've already told. And this method prevents the excessive contraction of the muscles above the level of the amputation. That will prevent the deformity formation. Now, what is the myoplasty? In all cases, the myodesis is preferable, except the one which is the peripheral vascular disease, where the vascular compromise is already there. In those cases, the myoplastic flap is important, because they had what is done here. The section muscle is the opposing muscles are sutured with each other. That means the agonist and antagonist that should be sutured with each other over the bone, and that is basically that will help in increase vascularity. So in where the vascularity is the issue, myoplasty is the most preferable technique. Now, another important technique which is not very popular, that is the osteomyoplastic transtibial. It is especially done in transtibial amputation. It creates a very, very functional residual limb. As you can see here, the part of the fibula is a part of the fibula. It is partially cut. It is rotated, and along with all the muscles, it is fixed with the tibia, so that it is almost at a squat stump, and that is almost an in-bearing. It is absolutely very, very beneficial in-bearing stump. So that is the creation of the tibial bone bridge. It is a bone bridge anchorage. It is done. It is an artel technique. It is a tibial bone bridge is done, which provides a very, very stable, broad tibial articulation that can be capable of some distal weight bearing. So that is the most. It is not very popular, but that can be done. Now, what is the tricks for the amputation in children? In children, wherever we have to preserve the length, because that will grow in future. We have to preserve the growth plate. Next, we have to perform the disarticulation rather than the transosseous amputation, because that will help in better functional recovery. We have to preserve the knee joint wherever possible. We have to stabilize normalize the proximal portion of the limb. It is very, very important, because ultimately during the growth, there is a possibility of deformity. As I already discussed in the transfemoral amputation, there is a possibility of flexion and abduction deformity. So in that case, we have to stabilize the proximal portion of the limb. Is extremely important. Now for the toe amputation, what are the problems? If you cut the great toe, what will happen? There is a problem of balance. Whereas we have to, if you cut only the second toe, there is a hallux deformity. Now, what is the ideal site of toe amputation? It should be just easily asked, and that should be done through the base of the proximal phalanx. Why? Because there is a metatarsophalangeal joint. Is basically it is the fulcrum during the locomotion. There is a fulcrum of the third class liver. That is during the locomotion. This is this plays a very, very important role during the locomotion. It is a propulsion. Now, which function is lost if disarticulation or through metatarsophalangeal is done? It is basically it is a balance. It is a question of lack of balance. Another important point is the rocking action is lost. So if it is done, then we have to add the rocking action with the prosthesis by the 4-foot rocker system. Now, ray amputation. If we remove the first ray, what will happen? That will lead to lack of balance. We have to give the balance training. If we remove the second, third, fourth, any one or two or three ray, second to fourth ray, that will lead to that is reduction of the transverse arch. But if it is the fifth ray is removed, that will lead to discomfort in the mid stance, as there is loss of rollover function, because the fifth ray is basically a weight bearing ray. So it is extremely important. If at all we have to remove, then we have to remove from up to the base of the fifth metatarsal. Base of the fifth metatarsal should have to be preserved, because the most important structure is already attached with this, that is the peroneus brevis tendon. Next is the transmetatarsal. If we remove the foot from the transmetatarsal through the metatarsal, what will happen? That will lead to discomfort during stance and forward propulsion. And also there is the equinus deformity. From metatarsal onwards, if we cut much more up to the Symes level, up to the Chopart level, so that will lead to equinus deformity or equinovarus deformity. As you can see here, these are the types. This is the Symes amputation through the ankle. It is a Chopart. There is a mid-tarsal that is between the talus and the navicular, calcaneum and the cuboid. Transmetatarsal amputation through the metatarsal, but here that at least the base of the fourth, fifth metatarsal should be preserved for preservation of the peroneus brevis tendon. Another is the Lisfranc, that is a tarsometatarsal. It is an amputation through the tarsometatarsal joint. Again, it is very disadvantageous because there is high chance of equinovarus deformity. Why equinovarus deformity is developed? Because the dorsiflexors is lost. There is no dorsiflexion, but there is a powerful plantar flexion is there. That is the gastrosoleus. So gastrosoleus overpowered, that will lead to equinus deformity. Not only that, there is a whole of the body weight is concentrated on the calcaneal tuberosity, and that will lead to plantar ulcer. So how it can be obviated? The plantar flap should be long enough to fold up to the dorsum of the foot, and that has to be tied without tension. This is most important. See, this is the third class lever, as you can see here. So this is the fulcrum. This is the actually basically the force, and whole of the body weight that will come in between. So that's basically it is a second class. It is a second class lever, and that is the metatarsophalangeal joint plays the most important part during propulsion. And see, this is the radiograph of it is the transmetatarsal, and this is the reamputation. Here the base is kept for prevention of the varus deformity, where the peroneus brevis tendon is preserved. As you can see here, see, there is a varus deformity. The equinus and varus deformity is already there. So how to prevent the equinovarus deformity? For the Lisfranc, we have to preserve the attachment, like the already have shown, to release the deforming force. So how it can be done? In Lisfranc amputation, they already I'm told the fourth and fifth metatarsal should be divided from the base of the fourth and fifth metatarsal should be kept for preservation of the peroneus brevis tendon, whereas the tendoachilles, that is a percutaneous release of the tendoachilles done. There is 2 cut on the medial side and 1 cut from the lateral side, so that the tendoachilles is released, and that will prevent the overpower, that will prevent the equinus deformity. So percutaneous lengthening is required. Now for the chopard, so there is strategic myodesis. This anterior tibial tendon extensor digitum brevis, that is the dorsiflexors are actually attached. It is close to the plantar fossa. So that will keep the stump dorsiflexed. Along with that, we can do this percutaneous tenotomy of the tendoachilles. Along with that, we can transfer the peroneus brevis to the cuboid and transfer the anterior tibial tendon to the neck of the talus, so that we can increase the dorsiflexors power to the stump. So the signs, I'm not going into, all of you know the signs is amputation is through the ankle. I'm not going to detail. So all of you know, it is very, very important. We have to use this such foot. These are for the prosthesis is aligned with modified external keel or such foot. This is you can use that. And most important complication of the SIMS is there is some displacement of the pad of fat, and this pad of fat should be tied at the center of the tibia. This is most important. Otherwise, it can be this suturing can be done through the drill holes through the tibia, because this accurate anchorage and centering of the heel pad is extremely important for the weight bearing. This is a weight bearing amputation stump. Now, transtibial amputation, I already told, cylindrical stump is very important. So this sort of stump, as you can see here, because less energy expenditure and the better propulsion is required through this below-knee amputation. The candidates are basically, if we keep this in this manner, candidates are have better functional recovery with patellar tendon bearing prosthesis. Now, knee disarticulation, as you can see here, it is relatively disadvantageous, and is for the either the below-knee amputation or the transfemoral amputation is much more better than that. This is a transfemoral amputation, as you can see here. This is the sort of amputation, the endoskeleton, and this is a very short femoral prosthesis. Very short femoral prosthesis for the child as well as the adult, as you can see here. Now, hip disarticulation, especially for the malignant tumor in the lower part of the femur, where it is extracompartmental, that this disarticulation can be done for the lower limb, for the child as also for the adult. For the upper limb, similarly, wrist disarticulation or transcarpal amputations, there is through transradial amputation, there is a below elbow disarticulation, above elbow amputation, and the 4/4 amputation can be done. Now, transradial, as you can see, this is a transradial amputation. This is a myoelectric prosthesis is added, and the patient has, if he do the proper physiotherapeutic measures, rehabilitation, that can do the every walk properly. This transhumeral amputation or shoulder disc is a myoelectric hand, as you can see here, the myoelectric hand. Now, what is the post-operative care? It is usually asked in the examination. There may be physical care, there may be biomechanical care, the biological care, or the psychological care. There are 4 forms of post-operative care. Now, physical care is basically the splintage. Which sort of bandage is used? It is asked. Which sort of splintage is used? I will discuss in the next slide. Now, positioning of the stump, it should not be kept. The amputation stump should not be kept over the pillow, over the edge of the bed, or crotch handle, because that will invite contraction. Next is the stump hygiene is extremely important. We have to use we have to wash the amputation stump clearly, and we have to clean regularly. Otherwise, that will lead to significant damage on it. And patient should advise. So for this sort of position should be encouraged, so that will help in prevention of the contraction. And this sort of practice should be absolutely abundant. This is sitting by the side of the board, the side of the bed, over the pillow, side of the bed. That will invite the contraction. Now, what is the biomechanical advices? Early restoration of the ambulation can be done either with the help of the crutch or the pylon or the wheelchair, or some modern gadgets will come. There's muscle power should be developed, and there's the activity of the daily living training should be done in a proper way. Now, biological care is given in the form of the massage, tapping, desensitization. This is extremely important. It's a biofeedback where there is a little bit, there are several objects, like very soft object to a very hard object, and then very rough objects are gradually it is coming in. It is touched with the amputation stump. Initially, very like cotton balls. Cotton ball, the touching is started with the cotton balls, then it is coming to the newspaper like that. There's some little bit the paper, they're like papers, then the clothes, now smooth clothes, then rough clothes like that. There are the different types of sensitization. This basically is known as the biofeedback, and this biofeedback will help in development of this amputation stump, maturation of the amputation stump. And scar mobilization is extremely important. We can tap the scar, we can move the scar a little bit. Once it is healed, we have to move the scar over the underlying structures. That will help in scar maturation of the scar also. And not only that, then the most important, psychosocial care should be given for proper cope up with the society. Now, splintage of the stump, which sort of bandage is ideal one? The most important is the rigid dressing, because post-op POP cast, plaster of Paris cast is applied. That will not only prevent the edema, it enhances the wound healing, it decreases the post-operative pain, it reduces the hospital stay, it helps in maturation of the amputation stump, as also for help in early temporary prosthetic fitting. Soft dressing, it is initially it can be applied, but this hard dressing is much more beneficial than the over the soft tissue. Now, what is the early amputation? Early amputation aids, walking aids. This is basically the pneumatic post-amputation mobility aids. It is done for initial period. Once the stump is not become completely matured enough for production for use of a permanent prosthesis. So during this period, so just after the healing of the skin wounds and after before giving the actual prosthesis, we can use this PPAM aiding, that is the pneumatic post-amputation mobility aid. Otherwise, it is a little bit sophisticated. Otherwise, it's simple. There is a plaster of Paris and with some small either metallic rods that can incorporate with this plaster of Paris. That is a simple indigenously made pylon prosthesis. It is given temporarily. That will help in benefit. That will help for regaining of the confidence of the patient during mobilization. That will help in maturation of the stump, as also increasing the capacity, increase the contractility of the muscles around the stump. Now, what is the post-surgical period? We have to give some we have to give the time for stump maturity, which is maximal is seen in between the 6 to 8 weeks. I'm not going to detail. The same care should be given. Stump bandaging, we have to the most important cylindrical stump. It is the ideal one, but sometimes it is conical. This sort of stump is developed, but cylindrical should be the ideal one. Now, stump exercise, there are several stump exercises should be started from the third postoperative day. From agonist, antagonist, both the muscle groups should be allowed, should be encouraged to become developed. The ideal skin of the stump, it should be delicate, it should be healthy, free from the ulcer and sinus, and should not have any scar which is fixed to the underlying structure. Now, ideal scar, it should be atrophic. It should not be. It should be atrophic. It should be thin, fragile, easily breaks. But the hypertrophic scar should be discouraged, because that will help the very friction with the amputation socket, this prosthesis socket, that has to be discouraged. Ideal scar should be non-tender. It should be freely mobile. It should not be neither adherent nor infolded. And for the ideal scar, the upper limb should be terminal. For the lower limb, it should be posterior. Now, the complications. I think there are several complications. I think I can stop here. And I can questions. I can have some questions, and then after that, if I had the time, I can discuss about the complications.
Thank you very much, sir. So,
Yes.
Yes, sir. So I think for DNB, if you have any question, please ask. So, meanwhile, I have a few questions about,
Yes.
as you mentioned, in the myoplasty,
Yes.
in case of vascular, when the vascularity is compromised. So, sir, in case of traumatic or when we are doing amputation for crush injury, which one to be preferred, myoplasty or myodesis?
Myodesis is the most important technique which will have early functional recovery, because that is the muscle is directly attached to the bones. But where there is some vascular jeopardies like the peripheral vascular disease or peripheral vascular occlusive disease is already present, in that case, not the crushed injury is not the indication. But if there is the vascular jeopardy is already present, so in that case, myoplasty is the most important. But in all the cases, we have to try for the myodesis.
So,
Determined to some extent by the injury. Okay, so it's not always that you can get a perfect flap with the posterior or anterior thing. You have to see what skin is there on either side, how traumatized the skin is. And sometimes if you take long flaps in a traumatized area, there's a chance of it getting necrotic. So I think you have to use your judgment with your flaps. So Avinash is asking technique of myodesis.
Myodesis is basically the fixation of the muscle or tendons. Basically, the tendinous part is fixed to the bone. So how it can be done? There are two ways. One is basically the muscle can be attached with the periosteum. But here it is, we have to be very much careful. Periosteum should not be elevated much more over the proximal part. So in that case, another technique is basically, which is much more beneficial.
Drill holes.
That is the drill holes. Yes, drill hole that has to be strategically. Suppose for the transfemoral, especially the adductor magnus tendon. Adductor magnus tendon can be easily sutured with the anteromedial aspect of the femoral stump through the drill holes, and the hamstrings, basically hamstring can be easily attached to the posterior aspect. This is basically the ideal technique of myodesis.
So Avinash asked one more question, is about how to decide about closure to be done or not in case of vascular injury of lower limb. Yeah.
There are several sutures are already discussed, but the vascular injuries already there. Suppose most common is the simple suture is beneficial. Otherwise, there are some Algava Donetti stitches. If there are significant, the muscle bulk is already there, soft tissue is adequate, then we can go for that. Otherwise, very simple sutures with widely spaced, that can be very easy, and that should be ideal one for any vascular compromise. And another tips is, if there are some significant
to keep it
jeopardized, we can keep some spacious, widely spaced single sutures, but the skin edges are attached with each other with the help of adhesive tape. Adhesive tape is attached on the one portion across, and it is dragged across the suture, and it is spaced on the other side, so that will reduce the tension. Once the edema is subsided, that will have cause reduction of the size of the swelling, and that tapes are become loose. So that it's loose. The tapes are attached on one side, it is dragged across the suture and is placed on the other side. So that is the easy technique to reduce the swelling.
So one question about the Ganga score. Narayan has asked that Ganga score do not consider the vascular status of the limb, how it can justify amputation of lower limb due to transection of femoral artery after trauma with Ganga score less than 14.
Absolutely right. That is how it is already told. I have said separately, if there's some vascular injury, you have to add some specific other parameters, like the either Doppler study, or there is some transcutaneous percutaneous oxygen pressure measurement. So that is it. So simple score is not sufficient enough. That is, if a simple score is sufficient, then every robot can do the surgery, isn't it? We have to add some the expert. That is why they have given there some margin is 14 to 17. If it is above 17, it is clear-cut indication of surgery of amputation. If it is below 14, then we have to salvage definitely. But if the score is between 14 to 17, we have to provide our expertise, like the vascular status by clinical estimation, as also some this transcutaneous oxygen supply, oxygen measurement, as also the ankle brachial index.
So I think the reason for that is that once you have a vascular injury, then the whole thing changes. Okay, because all these scores will become irrelevant if the limb is not viable because of a vascular injury. Okay, so I think you have to look at other factors when there's a vascular injury, how delayed it is. So after 6 hours, you would be hesitant to revascularize the limb, etc. So the whole sort of idea of the soft tissue injury part of it to assess whether the limb can survive or not changes dramatically if there's a definite vascular injury.
Exactly.
So,
same thing happened if it's a significant nerve injury.
nerve injury.
If there is no sensation, so there is scores are valueless. There was no sensation.
Yeah, but at least nerve injury is a different, you can assess to decide whether and give it a score. The problem with vascular injury is that if there is no vascularity, then everything else becomes secondary.
Exactly.
And also about 6 hours, sir, do you consider in case of children, what is that 6 hours is okay, or we should?
So I think this 6 hours is not a definite number. Okay, so it varies with the kind, how long it's been completely ischemic, whether it's warm ischemia or cold ischemia. So it's difficult to give a definite answer saying that in children, 6 hours, you can definitely wait, give the, in children, expect it to survive even with a slightly greater amount of time that is under ischemia. But there's so many other factors that come in. But generally, I mean, that cutoff is not purely on just 6 hours. It's on other factors also. So if the muscle is dead or not, you need to look at all that. So if the muscle is dead, then there's no point.
And so just I want to ask about that one. Whenever you have doing the vascular repair, with that one, usually you do the compartment release. So it is always essential to do release of the compartment distal to that.
Prophylactic, yes. Prophylactic release of compartment is absolutely mandatory.
I think almost always, more or less, because very rarely do you get to do it within an hour of the vascular injury. Okay. So by the time the patient comes to you, goes into OT, it's always 2 or 3 or 4 hours or more. Huh? So I think when you reperfuse the limb, there is going to be rebound swelling, and you need to then prevent that with a prophylactic fasciotomy to make sure that the swelling doesn't cause compartment syndrome.
So one question from Dr. Gunjan Upadhyay is that in sequence of repair, we follow the protocol of bone, extensor tendon, flexor tendon, artery, nerve. When to repair veins and in what priority? His question is that.
Yes. So preferably vein should be repaired last, because if we close the vein fast, so that will lead to increased edema formation. So vein should be actually repaired last. So arterial repair should be done fast, followed by the vein.
So, and one more question, what he has asked about the Ganga hospital score is only regards to type 2B Castillo and or more, or we can apply it for every injury.
Yes, it is applied for every injury. It doesn't have any particular injury. It is considered all the nerve injury. Now there are vessel injury, skin injury, but there is no particular injury is considered.
So I think its real value comes in the 3B type of injury, not 2B. There isn't a 2B as far as I know. It's
3B you want to write, yes.
Because 3B can be a huge spectrum of injuries. Okay, if you look at 3B and look at the Gustello-Anderson, it's a huge spectrum starting from something that is not so bad to something that is really bad. Huh? I think that is where the Ganga hospital score comes in trying to look more closely at the various parameters rather than just A, B, C of the Gustello-Anderson. Okay, so 3B is where the score really has its value. I think in 2 and 1, I don't think the soft tissue injury becomes such an issue. Okay, there are other factors like the vascular injury, etc., that become more important. But the soft tissue injury, there's also the AO system where they look at all the Sherny classification for closed and open injuries, which is also important to have some idea about, because it looks at all the various groups of tissues, starting from skin, that is the integument, the muscles, the vessels, and the nerves as well. Okay.
So that Cerny classification is for that closed fracture, sir.
Yes,
It's got for both closed and open. Yeah. But he was the first one to talk about soft tissue injuries in closed fractures, okay? Because in open fractures, everyone was talking about it, but for the importance of soft tissue injury in closed fractures was first brought about by. And in that book, he's written a small book, which is really good to read for people.
Okay. So if I got some time, I can discuss about some complications.
Okay. Are there no more questions?
So just one or two technical questions. So like while doing amputation, there is one very common problem for dog ear sometimes. So how to manage that?
Yes, that is a standard surgical technique of removal of the dog ear. So in that case, once we remove, so first of all, we have to see whether the skin is redundant or not. So in that case, so we have to close it. We have to see whether it is freely mobile or is very tight. Okay. So if it is freely mobile, there is some redundant. We have to make a little bit, cut it, and we can make a form closer. So in that process, if there is some dog ear formation, then we have to hold the edge, the strangle, that is end of the skin with the help of the Alice forceps. We have to cut it and just cut that portion, and again we have to stitch it. There is a standard technique.
And so which one to be preferred, corrugated drain or Romovac when doing the close?
In my practice, I will always use the corrugated drain. Corrugated because it has multiple channels, and that can help in drain properly, because there is no question of very tight closer. I always use some loose closer, because there are some collection, and collection should come out.
Yeah, especially in the sort of open injuries, then I think elective procedure for tumor, etc. It's a different situation, and when you're doing it for emergency procedure for amputation, it becomes a different way. So you would not like to close the wound too tightly whenever you do it, because you always want the drainage to come out.
So you're muted in between, sir. So can you please? I think the connection problem.
I said that when you're dealing with amputations which are for emergency traumatic conditions, then first you'll very often leave the wound open. And secondly, when you close it, you don't always want a very tight closure. Okay.
Okay, so, and so I just want to ask few questions which is asked in previous DNB. One is a little confusing. So that one, I'll just ask about that one, then you can consider. Like, so one thing they have asked repeatedly is about the surgical principle of amputation in children.
Yes.
So how it is different?
Yes, I have already shown it. This surgical principle in children is depends on. So we have to keep, as long as it should not go by the fixed, there is 4, 6 inch like that. We have to consider as much as bone should be preserved. That is one. We have to preserve the epiphysis. Always the epiphysis should be preserved. Next one is the joints. Always joints should be preserved as much as possible. Next is the myodesis should be done appropriately. So that is suturing of the muscle should be done appropriately, especially in the proximal part, so that that will help in recovery of the muscle function. That is most important. Another is for the lower limbs, the below knee amputation. There is a possibility of bony growth of the stump. So in that case, I can show in your complication part. So in that case, we can block the canal. So in my complication part, it is there. Especially for the children, there is a possibility of overgrowth of the bone of the stump. So in that case, that will lead to some, again, there are some soft tissue problem. There is sinus formation. There is a bone may be exposed to the bone is coming out from the skin, the sutures. So in that case, we have to close the canal. This is a special technique I'll show you.
So maybe you can go to that. We have about 7 or 8 minutes left. I hope you
Yes,
can.
I'm just, yes, I'm coming.
Yeah, finish in that time, then we can have any further questions.
Please, sir.
Yes, yes. Yes, complications is there is a pain after complication. It is maybe nociceptive pain, it may be neuropathic pain or the structural pain. So basically, what are the nociceptive pain? Is the pain is an post amputation pain or is a residual limb pain. These are the two types of nociceptive pain. Neuropathic pain may be phantom limb pain or the phantom limb sensation, whereas the structural pain may be related from the musculoskeletal and the vascular or the neuroma formation. When neuroma formation, especially, it is diagnosed by this very, very localized pain, which the tinel sign is positive and it is relieved by the local anesthetic. So this is most important. So how basically in this slide is very important slide, but there's a question is asked, how do we differentiate the phantom limb pain from the neuroma pain? The phantom limb pain is basically is a more intense in the distal portion of the phantom limb. Somebody is a below knee amputation, patient will complain of severe pain is coming from the ankle or the toes. The most distal portion is maximally painful as per phantom limb pain, and that can be exacerbated by or it is precipitated by the physical factors like the pressure, time, or the weather, or the psychological factor, that is basically the mental stress. And the nature of this phantom limb pain may be sharp, cramping, burning, electric, jumping, like that. But the neuroma pain, basically neuroma pain is basically, it is a very, very localized pain. It is tender on touch, and there is a tinel sign is positive, and there is a it is relieved by local anesthetic. This is basically the questions. Now the prosthetic pain, there are several causes of the ill-fitting socket, incorrect alignment, incorrect done prosthesis, or excessive sweating on the skin breakdown. Pain due to complication may be bony projections, there is bone spar formation. I will come later on. Neuroma is already discussed. Infection and the adhesion of the scar, especially the hypertrophic scar. Now, edema, it is already told how the edema can be relieved. There are some early the bandaging, appropriate bandage, rigid dressing, and that is a pylon prosthesis or the sophisticated the ambulation aids, which that is a sophisticated ambulation aids can be used for reduction of the edema. Now, terminal bone overgrowth, as you can see here, it is cut is a very high level, but during the passage of time, there is a growth overgrowth of the bone is developed, especially seen for the child, and it is required surgical resection, or it can be done in initial period by capping capping of the bone with a synthetic device or the bone grafts. As you can see here, the bone grafts is applied on the end, and the little bit periosteum is elevated, and some bone chips, that is cancellous bone chips, is applied, and it is sealed. Bone cavity is sealed with the help of the screw. One screw, it can be removed later on, or through the help of the K-wire. This is the way. This is the just after maturation of the bone spur. That will help in the reduction of the terminal bone overgrowth. Now, the bony spar is seen in the adults. You can see, as you can see here, this is a bony spar formation. It is difficult to fit into the total contact socket and requires some revision of the amputation. Otherwise, distal air chamber socket may be used. Now, deformity is already told how the deformity develops because of the improper postoperative care. Without there's an inadequate stump exercise, faulty positioning of the stump. Long stump. If you take the long stump, that is very difficult to control by the muscle. Then that will lead to deformity. Now, for the ankle, what develops is equinus and varus. I already discussed about. For the knee, the flexion deformity. Hip is abduction flexion deformity is already discussed. Now, how to prevent the flexion deformity of the hip? There is a pillow under the thigh. Soft mattresses are forbidden. Encouraged to lie prone for 15 minutes 3 times a day to stretch out any early flexion contracture and to actively adduct the residual limb to prevent the abduction contracture. Now, active extension of the residual limb. While this is another special technique, that is we have to flex the normal limb and ask to extend the residual limb. So that will help in stretching of the muscles. Now, excessive wheelchair use, which encourages the contracture, is discouraged by using the walking with the PPMs, that is the pylon, or crutches, or the walker. But standing with stump, resting on the crutches is forbidden because that will help in contracture formation. Now, knee flexion deformity, how it can be prevented? There is circumferential rigid dressing. It is very helpful for the reduction of the edema and prevention of the capsular contracture, and that will replace, and that rigid dressing should be replaced weekly for 3 weeks with a full range of knee motion is encouraged at that each change during the change of that. That for 3 weeks it is to be kept. This is very extremely important. Even after the cast, pillow should not be used under the residual limb, or the hip flexion contraction may be encouraged. Now, deformity of the deformity if at all develops, what will do? Now, below knee amputation up to 15-degree flexion or above knee amputation up to 25-degree is allowed for prosthetic application. But if the deformity is much more, what to be done? For that is it requires a contracture release. That is a posterior contracture release to be done along with the lengthening of the hamstring. But it is contraindicated if there is a limb is already vascular compromise. So what should be done in case of vascular compromise? If there is a very short stump with significant flexion deformity, if even up to 90-degree, then there is another prosthesis where the socket is it is made in such a way that bent portion of the amputation can be accommodated through that socket. This was a bent knee prosthesis, which is specifically used for the vascular compromised patient. Very short stump with more flexion contracture requires higher level prosthetic application. Now, these are the sinus or ulcer formations. You can see here already told because of the hematoma infection, sequestrum that causes sinus. Treatment is antibiotic, dressing, debridement, back application, delay the prosthesis. But in such a situation, if such a situation develops, only the revision surgery will help. Now, muscle power, I already not going into detail. Neuroma formation is already it is done. Now, phantom limb sensation is extremely important. Once it develops, it is very difficult to treat. Everything can be done before its development. That is, prevention is better than cure. So there are several the techniques like the analgesic sedative, early stump exercise, early pylon prosthesis, relaxation training, biofeedback, desensitization. Already I have shown what is the technique of desensitization that will prevent the phantom limb sensation. But once it develops, it is very difficult. So in that case, psychological counseling and the nerve block, sympathetic local nerve block or the epidural nerve block is only very helpful. Now, trigger point. Sometimes there is a trigger point, a sensitive spot on the stump, which causes the pain when touched lightly. Apart from the neuroma formation, that is a separate entity. Although it is intermittent pressure that may be it develops intermittently. But if it is a neuroma formation, that trigger that tender spot will remain constantly. That is the basic difference. So how it can be treated? So that can be treated either physiotherapeutic measures. There is psychological counseling. That is the physical measure. That is tapping. That is tapping over the painful area, and the modification of the socket. That is a total contact socket can be used, distal air chamber socket, by which will basically change the weight bearing area. Now, redundant tissue, if it is there, redundant soft tissue like skin and the muscles, we have to there will be no total contact socket should be used. We have to use the distal air chamber socket, or otherwise we have to do the revision surgery. Now, dermatological problem like contact dermatitis, detergent, nickel, because these are coming in contact from the prosthetic wall, that can lead to contact dermatitis. And there is a bacterial folliculitis, wart-like overgrowth. So basically, this is the complications. So if there are any question, I can discuss.
Great. Thank you very much, Dr. Pal. That was excellent. The phantom limb, the only thing about the phantom limb is remember that it is very often a sensation that the limb still exists. That's why it's called phantom limb. You have an amputation above the knee, but the patient feels that the rest of the limb is there and he feels pain in that. That's why it's called a phantom limb, is because the limb is not there, but you feel that the limb is there, or so nerve connections to the brain haven't yet fully gone, and the patient will feel like the limb is still there, and he will have unpleasant sensation, pain, etc. in that limb. And that is something which needs a lot of attention to. It needs counseling to explain the thing to them. That's the first and most important thing, is they worry about it because they're wondering what it is. So you need to explain to all of these that this is something that will happen and it takes time for it to go away.
Exactly.
So just one question which usually patient asks to us is that when they can put the prosthesis. So what is the answer for that one?
Yes,
Because
once there is a fully maturation of the amputation stump, there is an actual answer is that final prosthesis can only be fitted after complete maturation of the amputation stump. Now, what is the criteria of the maturation stump? That is the same criteria. What is the ideal amputation stump? I have already shown it. That is, the skin should be absolutely, it is held. There will be no significant, no hypertrophic scar. It should be a normal sunset, normally vascular, normal appendages. The muscles are working. Normally, there is no deformity, and that there is almost full range of motion. Full range of motion is there, and there is ideal scar, ideal square shaped or cylindrical shaped amputation stump is already there, and there is absolutely, there is no pin, no trigger point. That is the maturation stage. So if the amputation is completely, amputation stump is completely matured, this is the ideal one.
So
and that is the time,
basically after
8 weeks.
Because basically after the amputation, there will be swelling in that limb, and if you then go and fit the limb, within a short time, when the swelling disappears, that limb is not going to fit. So you need to bandage the limb, wait for all the swelling to go down, the edema to go down, the sutures to well heal satisfactorily. And so we are usually talking about, as you said, 8 weeks, 2 to 3 months after the amputation that you would do the fitting. But it's not related to exactly the time, but you have to get all this shape of the stump correct. You've got to get all the edema out of it, and you have to be sure that the swelling is all gone, so that it's not going to then become loose in no time. I think that's great. I think we should call a close to this because it's almost 8 o'clock. Thank you very much, Dr. Pal, again for an excellent talk and discussion on a difficult topic to cover in such a short time. Thank you very much, and hopefully see you all next week. Okay.
Thank you. Thank you. Bye.
Bye.